Welcome to this episode of Morning Report Emergency Medicine. I'm Alec Weir. Let's get started. This is the case of, hey girl, are you a pulmonary embolism? Because you're making me breathless. And I chose this picture because I get confused for Ryan Gosling at least 2 to 3 times per shift. A 34-year-old male, no past medical history, never been to your department before, coming in with chest pain and shortness of breath. Says it's been going on for about 4 weeks, associated with some nausea and some vomiting. Denies any cough, diarrhea, fevers, urinary complaints, belly pain. No recent travel, no history of cancer, nothing else, but you can tell he's confused. I'm using a translator, and the translator is having to repeat himself over and over again, and even in my broken understanding of Spanish, I can tell he's not quite answering questions appropriately. Here are his vitals. He's febrile, his heart rate's 145, his blood pressure's soft, 97/73, breathing 30 times a minute, setting only 84% on room air. What's our resuscitation evaluation? So supplemental oxygen, right? He's only setting 84%. Give him some IV fluids. He's tachycardic, soft blood pressure. Give him some antibiotics, fever, tachycardia, low blood pressure, tachypnea. We've got surge criteria coming out of every direction. Gave him some antipyretics, did a bedside ultrasound, EKG, chest Xray, and some lab evaluations. So here's his EKG. Tachycardic, right around 150 beats per minute to sinus tachycardia. Slight right bundle branch block here. It's incomplete. The QRS is only about 100 milliseconds, but we have no old one to compare it to. So let's see that chest X-ray, right? He's tachycardic, he's hypoxic, he's tachypnic. That's the point of this case. This chest X-ray is going to be crazy. It's going to give you all the answers you need. This is the reason you're watching. It's normal. It's too normal, right? His X-ray is pretty clear. The heart might be a little generous, but nothing so impressive to be giving the symptoms that we're seeing in this patient. So let's go back to that EKG. Is there anything else we can look at that we may have missed that first time around? Well, I'm going to point it out. I'm going to say it. We're going to talk about it. The S1Q3T3, right? Oh, I can hear the groans. S1Q3T3, not sensitive or specific for pulmonary embolus, but in the right setting, we're starting to follow these breadcrumbs. So let's take a look. S1Q3T3, we have a deep S wave in lead 1, a Q wave in lead 3, and inverted T waves in lead 3 as well. But remember, we have no old EKG to compare to. So this patient got a CTA. You see our right ventricle and our pulmonary arteries here. We're heading towards the head, and we're going to scan back down. Pause here. We're starting to see some filling defects, both sides. And you can see how large this filling defect is. Again, bilateral. Here's our official read, the CT Angiography, large bilateral central pulmonary emboli. Also some indications of right heart strain given the enlarged right ventricle. And then there's a wedge-shaped area in the left lobe, which is concerning for pulmonary infarction. And now this infarction gives you the inflammatory response that causes patients to be febrile and have that low-grade temperature with pulmonary embolus. So I want to talk a little bit more about definitions, things we say, and what they really mean. Subsegmental pulmonary embolus, these are the pulmonary emboli that are way out in the periphery. Segmental, a little bit closer, a little more proximal to your pulmonary artery branching off the right ventricle. And then submassive. Submassive is anything with evidence of right heart strain. This can either be on CTA, where they show widening of the right ventricle. It can be elevated troponins or elevated BNPs, both of which ended up being present in this patient. And then there's the massive pulmonary embolus. So this is any of that other stuff, but your systolic blood pressure is less than 90. And with pulmonary embolus, let's talk about the breadcrumbs that lead you to this diagnosis. The medical student adage, tachycardia, tachypnea, and hypoxia, all present in this patient's case. Wells criteria and the PERC rule, can't talk about PE without talking about these. These help you to risk stratify patients. This helps to determine who needs further investigation into the diagnosis of pulmonary embolus. Both of these can be found very easily at MD Calc. Wells criteria gives you low, intermediate, or high risk, while the PERC rule says yes or no into who needs further evaluation. That EKG, right? Sinus tachycardia most commonly, but that S1Q3T3. If it's present, it's not sensitive or specific, but if it's present in a patient you're already concerned about, it can mean something. And then that chest X-ray, things like Hampton's hump or Westermarck sign, but in this case it was that clear chest X-ray. We were expecting pulmonary pathology, right? But a normal chest X-ray was concerning. The D-dimer, not very specific, but sensitive, and helps be delineated by your Wells criteria and your PERC rule. And then your ultrasound. Things like a plethoric or dilated IVC, or what's called a D sign, when you have bowing of your interventricular septum into your left ventricle, or McConnell sign, which is when you just have contraction of the apex of the right ventricle against that obstructed right ventricular outflow tract. This patient's hospital stay, he got heparin drip in the emergency department, IV thrombolysis in the ICU, and then went home on Viagra. He is a very happy man. So what are our take-home points? So you got to be asking yourself, hey girl, are you a pulmonary embolist? Because you're making me breathless. Patients with tachycardia, tachypnea, and hypoxia know the Wells criteria and the PERC rule and who to use them on. You can find these on MD Calc or any one of your medical calculating apps. The definitions of subsegmental, segmental, submassive, so this is evidence of right heart strain, or massive, a systolic blood pressure less than 90. Diagnostics, how does EKG, chest x-ray labs, and CT angiography all fall into making the diagnosis of PE? And then the treatment. In the emergency department, heparin or thrombolytics. Thanks for listening, and as always, you can follow me on Twitter at Weir_Alec or subscribe to this channel for more updates from Morning Report Emergency Medicine.